Talus view, the lateral, and also the PA projection. And then we have special views, including the Haas and the SMV, or the submental vertex. Haas. All right, first one here is the AP axial. AP axial. The whole purpose of the AP axial is, well, first of all, what you want to do, consider when you're taking skull x-rays, is you want to place the area of interest where? Closest to the image receptor, all right? This patient's an AP, so what do you think we're interested in looking at here?
The occipital?
The occipital bone, exactly. So we're placing the occipital bone as close to the image receptor as possible. Now, to visualize the occipital bone, we can't look at it straight up and down because you've got the facial superimposed on the occipital.
Angle pushes it away.
So we're going to use a very steep angle to throw the facial bones out so that we can visualize the elongated occipital bone. Does that make sense? Okay. So the baseline that we're going to use here is the, what's this? What's OML? Orbital meatal line. So what's your orbital meatal line? It's from outer canthus, okay, outer canthus to your external auditory meatus, okay? So that is the baseline that we're going to use. OML perpendicular to the image receptor, okay? What you're also going to do is you're going to go at the top of the table and adjust your patient's head so there is no rotation, okay? So now we want the mid-sagittal plane also what? Perpendicular to the image receptor. So you're going to go on top of the head, you're going to adjust the head so there's no rotation. So OML perpendicular, mid-sagittal plane perpendicular. Are you guys following? Okay. The angulation that we're going to use here is 30 degrees to enter 2.5 inches above the glabella. 30 degrees caudally towards the feet, 2.5 inches above the glabella. Now, to accomplish this, OML perpendicular to the image receptor, you have to do a really good and tight chin tuck. Okay? Some can't do that. Especially if you, let's say you got rear-ended by a car, now you got whiplash. You're not going to be able to do this. Okay? You're going to come in a more relaxed position here.
Just do a steeper angle.
Right. So now the baseline is going to change. We're not using the OML, we're going to use the IOML. Okay? And if you use the IOML, what's another name for the IOML?
Inferior.
No, what's the other name for it? It has a name.
Bottom of your eye hole.
Bottom of the It has a person's name to it.
The Free-Naza line.
The Reed's. This is the Reed's baseline. Okay. So now if they can't do a chin tuck, we're going to just use a slight chin tuck using the IOML perpendicular to the image receptor. And if you use the IOML, you have to use a steeper angle of 37 degrees. Make sense? Okay, again, no rotation to the head. IOML perpendicular to the image receptor with 37 degrees. Entrance is the same thing, 2.5 inches above the glabella. Okay? Questions? So 30 using the OML, 37 using the IOML. Okay? And these are some tips on correct angulation if you're unable to get them to do that proper chin tuck. Okay? You may have to bolster their head, or in some cases, if they're astenic or hypostenic, you may have to put the bolster underneath so that they can adjust their head accordingly. Okay? All right. Looks like the same thing. Okay, so the same thing here. So extreme chin tuck, this is what's called the Franklin head unit. It's done on an upright board, and there is a hole in the back where you can go behind the head unit and adjust the patient's head accordingly. Yeah, this is right behind the unit. Okay. So again, 30 degrees for OML, 37 for the IOML. And it looks exactly like this, okay? So again, it's going to be, it's going to throw the facial bones towards the feet. The the skull looks elongated, but it gives you a nice profile of the occipital bone. Okay? So for a properly positioned towns, the dorsum sellae should be projected within the foramen magnum. Okay? Where are the petrous ridges? Do we see the ridges?
Thick parts.
Right here, right? These are the ridges. Okay, so they should be symmetrical. That's also going to tell you whether or not you have rotation. Now, if you have underangulation, the dorsum sellae is going to be above. So instead of it sitting here, it's going to be up here. So if the dorsum sellae is up here, you are underangled. If you are overangled, now it's going to be somewhere down here, below the foramen magnum. Okay. All right, any questions? Talons is for what? Why are we doing talons? Which bone are we looking at here?
Occipital.
Occipital bone, okay. Okay, a lateral. Laterals can be done in any side. Again, if you injured the right side, it's going to be a right lateral. If interest is on the left side, you do a left lateral. Okay, so it is specific to the site of injury. Some of your hospitals will say, well, just do bilateral. That's part of the routine. Yes, no? Anybody do some skull work besides you two? Okay. So determine the site of injury, and the site of injury is going to be closest to the image receptor. Again, mid-sagittal plane, you want it parallel. Interpupillary, you want it perpendicular to the image receptor. Okay. The central ray is going to be directed 2 inches above the EAM. So find the hole in your ear and just go 2 inches above that, and you're good to go. Yes.
I have seen a mandible and they used a BB to be able to see things. Monitor.
To locate foreign body?
No.
Okay. Sorry.
It was just a regular mandible. No foreign bodies. Do you do that with a regular skull?
No
Do they do
BBs.
that?
I've never done BBs on a skull, so I don't know why. I don't understand what the BBs are for.
I guess I don't know why, but he taped one onto her face. It was she got hit in the face with a baseball, so.
Oh, okay. So the whole BB is just trying to put it around the general area, so the doctors know where to focus on when they see that BB.
It's like a pinpoint.
Right. It just helps them. They say, I heard here, then they'll put the BB around that area. So when they look at it radiographically, they know what specific area to focus on. Okay. That's what you meant. Okay. All right, any questions here? So by the way, we're doing the skull. What size image receptor do we need? 14 by 17?
10 by 12.
10 by 12. So something medium to small is what we need, okay? Here is an example of one where it's traumatic. Again, the key here is mid-sagittal, parallel to the image receptor, interpupillaries, perpendicular to the image receptor. Central ray should be 2 inches above the EAM. What's the purpose? What's the purpose of bolstering the
Put in a
head?
Santa.
Right. Well, what else? Because of the
Divergent
beam, okay? If you place the head right on top of the table, the divergent beam is going to cut off the backside of the head. So we're going to bring it up a little bit. This is for a trauma skull. All right? So what is the whole purpose of the lateral? What are we visualizing here?
Parietal bone.
Okay, it's good for the parietal bones, okay? So an entire skull is visualized. The cranium seen without rotation or tilt. Correct flexion and extension of skull. Optimal exposure factors, again, we're using medium KV. No rotation, we are assessing the superimposition of the EAM. So you should only see one hole in the head. You should see one sella tursicum. You should see one orbital ridge. I'm sorry? There's only one. But because it's lengthy from end to end, if you have any rotation, it's going to look like you have two. Okay? If it's end to end, it should look like one. But if it's like this, now you're seeing both ends of it. Does that make sense?
Mm-hmm.
Okay. You're absolutely right. There is one. Okay. One mandibular rami. Okay, this is your rami. Okay, so you should only see one set. If there's rotation, it's going to look like there's two. So again, the key here is to assess for over-rotation or over-tilt, you only should see one anatomical structure superimposed over its pair. Okay? Wings of sphenoid. Okay, lesser wings up there. No tilt, superimposition of orbital roofs. EAM should be 1. Lesser wings of sphenoid should also demonstrate as 1. So this is your criteria. This is your criteria for no tilt, no rotation. So greater wings here, lesser wings here. Greater, lesser. I should change that. Is that hard to see?
Yeah.
Okay, I'll fix that. All right. So lateral skull is for the parietal bones. What do you think this is for?
That's what I feel.
Frontal bones.
That's how I feel.
That's how you feel? All right. So again, put the anatomy of inches closest to the image receptor. So here we're looking at the frontal bone. All right. So we are, again, mid-sagittal plane, no rotation, OML, outer canthus to the hole in the head is perpendicular. All right, now what we're trying to do here is we're going to use an angulation to project certain anatomical structures out of the field of view. Now, PA, when we're doing a PA cranium, PA frontal bone, the average angulation is going to be 15 degrees towards the feet. Okay, when we say PA Caldwell refers to PA 15 degrees angulation towards the feet. It's going to exit the nasion. Where's the nasion? What's the nasion?
It's a bridge, right?
Here's your this is glabella or nasion?
Glabella.
And then right below that is the bridge is your nasion. Okay, so it exits the nasion. All right. Anytime we're doing a PA of the skull, it's always going to be exit at the glabella. I'm sorry. Exit at the nasion. For the 0 degrees, it's going to exit the glabella. Bless you.
What's the 34?
Okay, I'm going to tell you guys that in just a minute. Uno momento, por favor. Okay, so the PA 15 degrees Caldwell. Okay, no rotation. Mid-sagittal plane, again, mid-sagittal plane is perpendicular. We are good. The petrous ridges is going to fill the lower third of the orbits. This is how we know that we've got a properly positioned angled PA Caldwell. Okay.
She's taking a piss over there. Hey, the bathroom is out there, dude.
I thought that was Erica.
Yeah.
She made
All right. So do you guys see the petrous ridges? This is the petrous ridges, the very thick part of the temporal bone. So it's going to fill the lower thirds of the orbit. Now the question was, so here, if the petrous ridges are filling the lower thirds, this is PA 15 degrees. Here is PA 0 degrees, and it places the petrous ridges in the orbits. I'll explain why we do this, okay? But if it's 0 degrees, the petrous ridges are going to be in the orbits. PA 15 degrees caudal, okay? It's going to be in the lower third. Now, do you see what's happening here? Because here's 0, 15, what's happening when I'm angling down, what's happening to the ridges?
Pushing it downward.
They're going down. So what do you think is going to happen with 30 degrees?
Go down more.
It's even going to be further, okay, further below the orbits, okay? So here is a properly positioned PA 15. Frontal, this is to evaluate your frontal, okay, and your supraorbital margins. So we're looking for the impact right here. That's where the issue is. This is why this is the most common view. PA, 0 degrees. Entire frontal without distortion is going to be demonstrated. So this is the best view and projection without distortion of the frontal bone. That's why you would do 0. I'm not interested here, I'm interested here. PA15 includes this and includes this. You guys with me so far? Now, 30 degrees, now we projected the ridges even further below, so now the entire orbital margin is in profile. But it does distort the frontal bone, so this is not really good for evaluating the frontal bone. This is good for evaluating more of the orbits. And sinuses, I'll get to that later. Okay? Do you have this on your slides?
No.
Okay, go ahead and add it.
I'll do that later.
Let me know when you're ready. I heard a little whimper. Everybody got it?
Yep.
All right. Trauma patient, can't do anything here, okay? What they're doing here is that the patient is traumatized to do a 0-degree angulation. All we're doing here is we're matching the orbital medial line with our central ray. So these two have to match. This will give us 0 degrees. Okay, this is the same thing as 0 degrees because we're basically matching the infraorbital line. Okay, any questions? Okay. All right, AP versus PA. Can we tell the difference? How can you tell the difference? That's PA?
A is PA, right?
A is PA? You guys are saying this is PA? And AP? Okay. So
No, I mean AP. Yeah.
Ooh, somebody just said sockets. Who said socket?
Bigger.
Don't look bigger. We're not looking bigger. Okay? We're not looking bigger. Okay? Look at the distance. Look at the distance from the outer to the outer edge. Okay? Yes, they are bigger, but okay, if you are AP, okay, you said the sockets were going to get magnified, right? So the sockets do get magnified, which means that because they're magnified, they're going to be further away, closer to the edge, closer to the edge of the outer margin. Yes. Yes.
What is
You're so good. Also further away. And these are closer. Okay? All right. So what did we determine? So which is AP versus PA?
A is AP.
This. If it's AP, they're okay. So this is AP, yes. This is AP, this is PA. Okay, we got it?
Mm-hmm.
You think this is going to be on the test?
Yes.
I just said that. It's not. Okay, but we will hang up some films so that way you guys can evaluate the images. Okay, SMV.
What? Oh, I was
Why is
doing
everybody
that.
doing this?
That's how
Trying to
we
see if you
feel.
can do it. You can't do this without breaking somebody's neck. No. Okay. If you do have trauma, are you going to be doing this? If you have neck injury, are you going to be doing this? Okay. So definitely.
We have an old person.
We gotta do
Never.
Exactly. So this is a very, very difficult position to do. This is optional, so listen up to your department and find out if this is something that is done. But this, believe it or not, it is a common position that we do in radiology. But you can see that by doing this, you can't be taking your time. No, because they're not going to hold that position for you. So you need to get through this. This is even harder to do than, you know, an enema tip in your rectum forward barium. This is going to be harder to do. Okay? All right. So here, remember your IOML? Your IOML is going to be parallel with your image receptor. We're getting the vertex, the top of your head, on the image receptor. SMV is the direction of your projection. Submental, below your mental point, exiting the vertex, SMV. Okay? So central ray is going to be perpendicular to the IOML and the image receptor, entering 3/4 inch anterior to the level of the EAM. Okay, I'm going to keep this simple. Where is it entering? What is that? What is this? Entering at the level of the, what is it called? Is it Gonyan? Ganyan? What is this angle? Isn't it?
Mandibular angle.
I'm asking you guys. What is this called?
That's a sexy jaw.
The sexy
Sexy jaw. Okay. So it's at the level. It's at the level of the
Sexy
angle or the sexy jaw. All right. You guys have to go through this very, very quickly. It is tough to do. They're even using a trash can to hold the image receptor. Oh my goodness. So,
Is that the new trash can?
this is a new trash.
Like old trash can?
So when we practice in the rooms, you will be sitting on a chair like this. So when you have the chair underneath your patient, don't be using a chair with wheels. Okay, make sure it doesn't have any wheels. We will practice this. Okay, we will practice this. I'm just going to show this to you now. It's better demonstrated in the lab. Okay, so the entire skull is going to be visualized. The mandibular condyles are going to be anterior. Mandibular condyles, right here. It's going to be anterior to mandibular condyles anterior to the petrous. Sorry, which is right here. What's this?
Mastoid.
Mastoid air cells. Mastoid air cells. Okay. But no rotation or tilt. Now, in a properly, you guys listen here. In a properly positioned SMV. What is that? What?
C1.
That's like the odontoid.
The odontoid of what?
C1.
Is it C1 or C2?
Of C2.
The atlas is C1.
C2.
So so this is the odontoid C2. So the odontoid of C2 should be projected right in the middle of your foramen magnum. That's usually how you know whether or not you've really got a good SMV. The other thing too is, with a good SMV, okay, your mandible should be superimposed over your frontal bone. That is a good SMV. Okay? So your mandible should be superimposed with the frontal bone. Okay. Special views. Yes?
We call the SMV Fuchs at St. Jude. Is that?
Similar to that.
Oh, it's not the same.
Yeah, it's not the same thing. Okay, but it's very similar. The Fuchs is actually, you are looking at the odontoid over the foramen magnum. It just has, it's the same thing, it just has a different name. Okay. Similar but different. Okay. The PA axial. Okay, PA axial. So remember the towns? Okay, patient has head injury to the back. They're laying down. What if they can't put their pressure? What if they can't put pressure in the back of their head? This is the opposite view now. It's called the Haas method. Why do they just call it the opposite towns method?
Because Haas figured it out.
Haas, exactly. Okay. So this is just the opposite. So we're still looking at the occipital bone, but now everything is reversed. So we're going to do PA, instead of angling towards the feet, we're going to angle towards the head. Okay? Which line are we using here? What is it?
Eye hole.
Eye hole. So it's the outer canthus to the ear hole, so that is orbitomedial line, okay? So your OML is perpendicular, central ray is going to be 25 degrees cephalad. 25 degrees cephalad. Okay? Similar to the AP axial. Dorsum celli is going to be sitting within the foramen magnum. You guys see the dorsum celli? Okay, now you see it?
There it is.
Dorsum celli sitting within the foramen magnum. Because the back of the head is further away from the image receptor, it is going to be magnified. Yes?
Are you gonna, I know that it has to be perpendicular and I know that there's an angle, but are you gonna teach us like where it's supposed to exit?
Oh, absolutely.
Because you didn't.
And in here? Okay. So it's just the opposite. So where's the entrance for the towns?
I don't know.
2.5 inches, okay, 2.5 inches above the glabella. So in this case, it's going to be exiting 2.5 inches above the glabella.
Ooh.
So the entry is exit. It's just the opposite, yes.
What if a person has a very small forehead? Like, I knew someone in high school whose forehead was like this big. Does that mean that the bones are different, or is it just
then it's just an inch above the glabella.
I think it's the hairline. Yeah, I don't
I was thinking about the shape
People are
of
different.
head.
No.
So if someone has very oval shape,
Yeah.
what are you gonna do? How you can angle it?
You just do your best you can. But again, we're using the baselines to do that. You just do your best you can. Great questions. All right, AP axial. Which radiograph demonstrates one or more positioning errors?
A.
A looks like it's just a big mess.
A looks like it's a big mess.
I agree.
B.
I mean, unless you want all of that. Because you got the alien, you...
Which radiograph demonstrates one or more positioning errors?
What's that hole?
The foramen magnum?
It's too high up. Isn't it? No?
Well, I mean, this is sitting right in the middle. This one is a little bit lower. But I mean, it's still within the foramen magnum. I don't think these are good images to even say there are errors. The errors are so minute. But the dorsum celli here is sitting in the foramen magnum. Dorsum celli here is sitting in the foramen magnum. Isn't that it right here?
No.
That's not it?
Washed out. Well, yeah, why is there... Why is that so dense? There's no air on A. A just doesn't look as good. Next.
Okay. Lateral skull. What's wrong here?
Yeah.
Okay. So.
Motion.
Where's the face?
So yeah. So there is some motion. What else are we seeing?
2 holes.
Do we see 2 holes?
Yeah,
Okay.
right
So we
there.
see one. We see what's going on. There's 2 of them there.
No, right over
One dorsum celli. What's this?
here.
Earrings. Okay.
Got some
so there's an
artifact.
earring there. What's this?
Some hair ornaments.
Whiskers? Those are whiskers?
Those are the hands. It's the hands. Yeah, so there's movement. So it might be somebody here just holding this girl's face during the study.
How do you know it's a girl?
But okay, I don't know if it's a girl. You're right. No, you're right. But the main thing here is there is a lot of movement going on. The other thing too is what I failed to mention in our lecture is that when you're doing the cranium, you don't need this. You don't need facial bones.
Okay.
Yeah. So they could have collimated a little bit better. And not only that, I mean, look, we've got facial bones and we've also got spine.
They're moving that much.
Yeah, and there's a lot of moving also. So that's going to be, so we've got a couple of things here going on. We got motion, we've got artifact, collimation's too big, overexposure. Okay. Okay, AP or 15 degrees. So a good PA places the petrous ridges where? In the
bottom
lower
third.
what?
Lower third.
Lower third. So which is your PA Caldwell, A or B?
A.
A, okay. And what do you think about this one? Because the petrous ridges are a little bit lower than the orbits, right? So is this greater or lesser than 15 degrees?
Greater.
Greater. So again, the greater the angulation, the further the petrous ridges are being thrown down. Okay, everybody got that? And again, do I need all this?
Yes, not.
That's just unnecessary exposure to the patient. All right. And then lateral skull. How is the tilt or rotation determined in the lateral? You guys see? One,
Double
two.
nines. Yeah.
1, 2. Double everything, right? Celetrissica, again, there's not.
Those holes right there, you're missing them.
Genetic.
Right here?
The middle, right there.
What's going on here? What are all these?
Hair ornaments.
They're not important. No, this is somebody who
Buckshot.
has some kind of brain surgery, because you can see where they cut the part of the skull off, worked on the brain, put it back on, and then they sutured it with metal clips. So, and the other thing too is when we're looking at bony anatomy, what is your scale of gray should you have? Is this long scale or short scale?
That's short scale. You need long scale.
This is long scale?
You need short scale.
So we want short
Yeah.
scale. This
Other
is
way
long
around.
scale, it's too gray.
Yeah.
Okay.
Other way around.
All right. What skull projection is this? Okay, so where is the petrous ridges? Is it filling the lower third? Yes or no?
Yes.
It is. Okay, so there's nothing wrong with the position. I think I'm okay with the position, but what else is going on here that's wrong?
There are markers in the anatomy.
Markers here, blockers here. So everything that we're trying to look at here, there is some kind of artifact in there, right?
Yeah.
All right. All right, that's it.
Sweet.